Hi everyone, my name is Hu Lang. I'm Associate Professor of Department of Orthodontics, West China Hospital of Stomatology, Sichuan University. Let me introduce my colleagues. Professor Wenyi Lai, she is Chair of Department of Orthodontics and Pediatric Dentistry. And Ms. Liu, she is an orthodontic postgraduate student. Recently, we published an original article in AGODO. Ms. Liu is the first author. Professor Lai and me, we are the corresponding authors. Today, we are going to share our article. Clear aligner therapy is gaining popularity among both orthodontists and patients for its advantages of aesthetics, comfort, and better oral hygiene over conventional appliances. However, among extraction cases, bodily retraction of incisors by clear aligner is a complicated tooth movement and requires adequate intrusion and torque control of incisors. But unfortunately, it is difficult to fully achieve. So additional root torque and intrusion of incisors, we call it overtreatment, should be designed to increase the predictability of tooth movement. Therefore, we conducted a finite element study to examine the effects of aligner overtreatment on torque control and intrusion of incisors for extraction space closure with clear aligner therapy, and to compare the biomechanical systems of aligner overtreatment with and without vertical rectangular attachments on canines.
We selected a healthy adult orthodontic patient requiring the extraction of 4 first premolars. Her maxillar and maxillary dentition from CBCT and intraoral scanning were obtained and transferred to Mimic's research software and Geometric Studio software to construct 3-dimensional geometric surface models of maxillar, maxillary dentition, periodontal ligament, and attachments, and clear aligner. Then we assembled all the components and converted them into 3-dimensional finite element model in HyperMesh software to mesh, and then imported into Abacus software and set up the material properties, boundary region, contacts between different surfaces of the components. We designed 2 groups in this study, with and without additional vertical rectangular attachments on the buccal surface of canine. Each group included 6 degrees, designed on the aligner overtreatment, 0, 1, 2, 3, 4, and 5 degrees. Aligner overtreatment was achieved through anti-clockwise rotation of anterior parts of aligner around the center of the first premolar aligner vacuous. Tooth displacement tendencies and equivalent stress of anterior teeth, periodontal ligament, and alveolar bone were analyzed.
In the condition of low aligner overtreatment, incisors were retracted with lingual tipping and extrusion. Canines were distally tipped and extruded, and second premolars were mesially tipped and intruded. These displacement tendencies were more significant with canine attachments than without canine attachments. Aligner overtreatment produced lingual root torquing and intrusion of incisors, distal tipping of canines, and mesial tipping of second premolars. These movements were more significant in the condition of canine attachments. With canine attachments, for each retraction stage, 1.2 degrees of overtreatment could result in bodily retraction of central incisors, while 2.7 degrees overtreatment for narrow incisors. Without overtreatment, stress was concentrated on apical and cervical area of both labial and lingual surfaces of periodontal ligaments. The stress value was higher with canine attachments. However, when overtreatment was added, the stress was more evenly distributed.
Clear aligner therapy for extraction patients caused lingual tipping and extrusion of incisors, distal tipping and extrusion of canals, and mesial tipping and intrusion of posterior teeth, resulting in a roller coaster effect during anterior retraction. Overtreatment is effective in controlling palatal root torquing and intrusion of incisors, resulting in bodily retraction of incisors, but less effect for lateral incisors than central incisors. Appropriate aligner overtreatment with canal attachments should be designed to ensure bodily retraction. For incisor retraction of 1 mm, 4.8 degrees of overtreatment should be designed for this model. Appropriate aligner overtreatment with canal attachments should be designed to reduce the likelihood of root resorption and available bone defects.